Okay, so we're starting chapter 16, ophthalmic surgery. This will be on page 587, but the lecture will start on page 588. Okay, so under the introduction to ophthalmic surgery is considered a specialty of microsurgery since it involves the use of the microscope on the majority of procedures as well as microinstruments. And so let's talk about the instruments and the equipment and supplies. So under forceps at the very bottom of that first column, you see the McPherson. Anytime you see McPherson, you want to associate that with anything with ophthalmic. And then it goes on to talk about your needle holders. There's the Castro Viejo, which is a locking or non-locking surgeon's preference needle holder. And so, yeah, McPherson and the Castro Viejos, very common to use. And you can see this on page 589, that figure 16-3. There's the Castro Viejo locking needle holder. Um, yes. Okay, under the scissors, on 589, it says Westcott scissors, spring action micro scissors, useful in strabismus and conjunctiva operations. So strabismus is a pathological condition involving a misalignment or deviation of the eyes that prevents them from working simultaneously to track visual objects. And so the Westcott scissors are going to be in that kind of procedure. Also at the bottom, there it is again, the McPherson Vanna's iris scissors. So McPherson. And then under the miscellaneous, there's the Bowman probe. It's for probing the lacrimal duct. And lacrimal is that facial bone that it's along the zygomatic bone and palate. It helps to form the orbit of the eye. Okay, so before we go on to the more routine equipment on page 590, at the top of 589, you have a big blank space between these two figures, 16-2 and 16-4. You need to write something very important between these two, and it has nothing to do with the instrumentation. It's just something that you need to know that I don't think the book tells you, and that it is imperative for you to know. So first you need to write is OS, and that means oculus sinister, OCULUS SINISTER. OS, that is the left eye. If you see on the board that you're doing a cataract extraction OS, that means you're doing a cataract extraction on the oculus sinister eye, which is the left eye. Under that, you need to write OD. That's oculus dexter, DEXTER. That is the right eye. So OS is left, OD is right. And then under that, you need to write OU. That's oculus uterque, which is UTERQUE, and that means both. So OS, OD, and then OU, oculus uterque, is both. Okay, those are very common abbreviations that you'll see on the board. All right, so on the bottom left on page 590, there's the phacoemulsifier. It's used in surgical treatment of cataracts, and cataracts are a pathological condition in which the crystalline lens has become opaque due to age or trauma. Uses ultrasonic energy to fragment the hard lens material, which then can be aspirated from the eye. It's a big blue machine. Well, it's not too big. It's about the size of a person. The phacoemulsificator, or emulsifier, excuse me. Okay. And then you have the routine supplies. And so that third bullet, you have the Wexel sponges. And these are little sponges on these little blue handles with it looks like an arrow tip, and it's a little sponge that you use to clear any fluid or liquid from the eye. And then you have lint-free microscope sponges, and then you have towards the bottom the BSS, which we're going to talk about here in just a minute. Okay, so under surgical intervention, the practical considerations, the second bullet you need to know, the non-powdered gloves should be used. If not available, the powder should be thoroughly removed from the gloves. So a lot of times you'll see your eye surgeons, your ophthalmic surgeons coming in and you'll have a basin of water and they will rinse off their gloves after you've gowned and gloved them. They will wash their gloves off in that basin, and then you'll hand them a towel to dry, and then they're going to proceed with the procedure. Extra care should be taken to keep lint off the instruments in sterile field to help to prevent formation of postoperative granuloma in the eye. So again, if we have powder on the gloves or any lint, that could create that granuloma in the eye. And then under the procedural considerations, that second one, periodically irrigate the eye using a syringe or small squeeze bottle filled with balanced salt solution or BSS to prevent corneal drying. And again, that BSS is an irrigant used for the eye during eye procedures. We have a bottle of it in the lab just in case somebody gets something in their eye. We do have BSS in the lab. So that takes us to our first procedure, which is that surgical repair of the chalazion. So under the anatomy, the meibomian glands are a type of sebaceous gland that secretes sebum from their ducts into the tears. And then a chalazion is a small lump on the inner or outer surface of the eyelid. Um, And so again, it's a small red inflamed lump that can be located on the inner or outer surface of the eyelid. It's caused by an inflammatory reaction to material trapped inside the meibomian gland in the eyelid. Um, yes, yes. That's why basically I just read the next two bullets. A red swollen area of the eyelid often characterizes chalazion. Okay. All right, and so that takes us to the second one, the surgical repair of entropion. So that first bullet about halfway down, it says there are two subunits. So talking about the eyelid, the medial and lateral canthus tendons. The medial canthus contains the lacrimal drainage ducts and the medial canthal tendon, which is a fibrous extension of the tarsus and surrounds the lacrimal sac. Okay, further across it says entropion, which is an abnormal inversion of the lower lid margins, causes the eyelashes to rub against the cornea, resulting in irritation, pain, and chronic tears. Usually entropion is due to the aging process, but it can also be caused by trauma. Okay, all right, so this is when your eyelids are kind of turning inward. Okay. All right, that takes us to iridectomy on 595. You need to write next to iridectomy that this treats glaucoma, Glaucoma. The iridectomy procedure treats glaucoma. So under the anatomy, the iris is a thin circular muscle suspended in the aqueous humor between the cornea and crystalline lens. It is continuous with the ciliary body and connected to the cornea by the pectinate ligament. The iris divides the space between the lens and cornea into the anterior and posterior chambers. All right, next bullet, the anterior chamber, which is the cavity of the eye located anterior to the iris and containing the aqueous humor, is the space located between the cornea and iris. Aqueous fluid flows through the space to provide nourishment to the tissue of the eye and maintain the shape of the eye. The fluid exits the anterior chamber at the angle where the cornea and iris meet through the canal of Schlemm and the trabecular meshwork. Next, iridectomy is removal of the section of iris tissue. This is performed to reestablish communication between the anterior and posterior chambers, relieving pupillary block, and to reestablish the outflow of aqueous humor through the canal of Schlemm, or the Schlemm canal. Angle closure glaucoma refers to the inability of the aqueous fluid to exit the eye at the correct angle due to blockage by the iris. This raises the intraocular pressure, or IOP, creating the condition known as glaucoma. If not treated promptly, acute closure glaucoma can damage the optic nerve and retinal blood supply, resulting in loss of vision. So if you turn the page, you can see a great sagittal section of the eye. Okay, so at the top it says the procedure is often performed at the same time as a trabeculectomy. A laser iridectomy can be performed for treating angle closure glaucoma. So I'm just reiterating here that the iridectomy treats glaucoma. And if I were you, I would write next to that that anterior equals aqueous and posterior equals vitreous. So the anterior chamber has your aqueous humor. The posterior chamber holds the vitreous humor. And so on this diagram, I have circled at the top right, posterior cavity, and then on the left, there's the vitreous humor that fills the posterior cavity, and that the lens, hang on, yes. So right here it says the iris. So I have the iris circled. You need to write next to iris that separates the chambers. Okay, because in the anterior cavity, if you look at the bottom, the anterior cavity is broken into two chambers, the anterior chamber and posterior chamber. It's the iris that separates the chambers and not the cavities. Okay, you have the anterior cavity, posterior cavity, which I think I used the wrong terminology a few minutes ago. So the posterior cavity, and so anterior cavity has aqueous humor, posterior cavity has vitreous humor. And you can see on the left, there's the aqueous humor in front of the iris. There's the lens. Now the lens separates the cavities, and I would write that too. So the iris separates the chambers, the lens separates the cavities. Okay. And then again, in the anterior cavity, it's made up of the anterior and posterior chamber, which I also have circled. So I circled 1, 2, 3, 4, 5, 6, 7 things on here, and I wrote that the iris separates the chambers and the lens separates the cavities. Okay, on page 597 under the preoperative preparation, that second bullet, there's that anesthesia, the retrobulbar block. This is a very common block. Anytime you see this, it's going to be on the eyeball, okay, in the eye cavity. Okay, so that takes us to our next surgery on 599, the strabismus correction for the recession and resection. So the extrinsic muscles, and extrinsic, that is the 6 muscles of the eye that come from the bones of the orbit and function to move the eye in various movements or directions. So the extrinsic muscles of the eye originate from the bones of the orbit and are attached by tendons to the sclera. The 6 muscles function in a coordinated fashion to move the eye in various directions, and although any eye movement may involve more than one muscle, each muscle is associated with one primary movement. So, several bullets down, it says strabismus is a misalignment or deviation of the eyes, which normally works simultaneously to track visual objects. And then that last bullet, recession or resection of the muscles of the eye may be used to correct strabismus. Recession is generally more effective when performed on the vertically acting muscle, and resection has a greater effect on the lateral rectus. So make sure you know the difference between recession and resection and which ones they're best used for. Okay, so under the procedure, number 7, the procedural consideration, a caliper, and you can see that picture next to that figure 1615, there's the Castro Viejo caliper. Make sure that you know that. A caliper may be used to measure the distance from the original point of insertion to the new one. The sterile marking pen may be used to mark the points of recession. So we're using a caliper, the Castro-Viejo caliper, on the strabismus correction. Make sure that you remember that. Okay, under the adjustable suture surgery on 602, it says an alternative addition to the method previously described is adjustable suture surgery. In adult strabismus, especially with diplopia, the adjustable suture technique allows more accurate alignment and placement of the field of vision is more exact. So diplopia is double vision. You may want to write that in the column somewhere. Make sure that you know what that is. So diplopia is double vision. And that takes us to 603, the scleral buckle. So you need to know that whole pathology and the anatomy part. The retina makes up the inner tunic, and again, tunic is an investing membrane. And it is the nervous membrane on which light and images are received. The outer surface is in contact with the choroid, and its inner surface with the vitreous body. Posteriorly, the retina is continuous with the optic nerve. The anterior portion extends to the ciliary body. The sensory layers contain two photoreceptors called rods and cones. Rods allow for seeing shades of gray and dim light and general shapes or outlines. Cones provide color vision and ability to see sharp images. Located in the middle region of the retina is the yellowish structure called the macula lutea. Within the center of the structure is a small depression called the central fovea, which contains only cones and is the area of highest visual acuity. Medial to the central fovea is the optic nerve. This area of the nerve contains no rods or cones, therefore vision is absent, and it is referred to as the blind spot. Retinal detachment occurs when the liquid in the vitreous cavity passes through a retinal tear, separating the retina from the choroid. Vision is lost wherever the retina becomes detached. Eventually, the entire retina will detach and all useful vision in the eye will be lost. So you can see on page 604 what is going on and the treatment the scleral buckling is treating. Okay. All right, so that takes us to 606, the dacrocystorhinostomy, or DCR. So the lacrimal system consists of the lacrimal gland, which secretes the tears that keep the conjunctiva moist, and its excretory ducts, which transport the fluid to the eye surface. The fluid is carried away by the lacrimal canals into the lacrimal sac and along the nasolacrimal duct into the cavity of the nose. The lacrimal gland is located within the upper eyelid by the outer angle of the orbit on the inner side of the external angular process of the frontal bone. Now you can see these openings in the inner corners of your eye on the lower lid. You'll see that little opening. That's your lacrimal duct. That's where the tears come out. Okay, second column, halfway down. 6 to 12 ducts exit the lacrimal gland and run at an angle beneath the mucous membrane. They eventually separate and open through several orifices arranged in a row along the upper outer portion of the conjunctiva. The lacrimal canals are located at the orifices called the punctum lacrimale. There are two canals, superior and inferior caniculi. The lacrimal sac is the dilated segment of the nasal duct. Then the last bullet, the procedure is performed when the nasolacrimal duct is obstructed by fibrous tissue or bone and has become impermeable to establish a new communication pathway between the lacrimal sac and the nose. Okay, so you have a really good diagram or picture of the lacrimal system right underneath. All right, on page 608, let's talk about enucleation. The globe of the eyeball in its entirety that includes the conjunctiva, sclera, and cornea, choroid, ciliary body, iris, retina, and crystalline lens. Okay, enucleation, that is an en-bloc removal of a structure, usually refers to the removal of an eye. So enucleation is excision of an eye due to malignant neoplasm, penetrating wounds, or when the eye has been so extensively damaged that no vision can be regained. Evisceration allows the retention of the sclera and extrinsic muscles of the eye. It eliminates corneal sensitivity and allows the patient to wear a prosthetic eye that will have mobility and a better cosmetic result. Okay, so on 609, again under pre-op preparation, there's that anesthesia, the retrobulbar block. Okay, so we are taking out the eyeball. All right, on 610, the keratoplasty or corneal transplant. The sclera and cornea form the external tunic of the eye. The sclera forms the majority of the posterior of the globe. The cornea forms the anterior sixth of the globe and is circular in shape. However, its shape varies at different periods of life, flattening out with age. So in the right-hand column, the cornea allows light into the eye and bends the light rays to help the lens focus them upon the retina. Then further down, replacing cloudy or damaged corneal tissue with healthy donor tissue through a corneal transplant will correct the vision. Okay, second bullet up at the top on 611, severe bacterial, viral, or fungal corneal infection that leads to corneal scarring. So there's various herpes viruses that are known to cause such scarring. So this is what's causing the scarring. The need for the corneal transplant are lots of bacterial, viral, or fungal infections. Again, under the pre-op preparation, there's that retrobulbar block. Under the practical considerations, during corneal transplant surgery, only the central part of the cornea is replaced, and corneal tissue comes from donors. So you can't have an autograft. It has to come from a cadaver. You can't donate from one eye to the other. You're going to be blind in one eye regardless. Okay. All right, so number 4 on page 612 in red, a trephine, and a trephine is a cylindrical saw for cutting a circular piece of bone. And you can see that on 613 on A, there's that trephination. Okay, I have that circled and underlined. A trephine is placed on the cornea and is used to make the corneal cut around the cornea and into the anterior chamber. Okay. All right, on 614, where it says Pearl of Wisdom, make sure that before you do any kind of keratoplasty, that you confirm that the donor cornea has arrived. Make sure it is either in the facility or better yet in your room before you start the procedure. And really with any implants from a cadaver, but more so with this one. All right, under cataract extraction, 2 methods of cataract extraction are commonly used. There's extracapsular, and that is the method for surgically removing a cataract through an incision in the side of the cornea and replacing the diseased lens with an intraocular implant. And then there's intracapsular cataract extraction, and that is a method for surgically removing a cataract by injecting alpha chymotrypsin into the posterior chamber to digest the suspensory ligament so that the diseased lens can be removed in its entirety. Those methods are available for removal of the opaque lens. With either method, an artificial lens may be inserted. So let's talk about that extracapsular cataract extraction. So the lens is a transparent biconvex structure that is situated behind the pupil anterior to the vitreous body. It is encircled by the ciliary processes and encapsulated in a transparent, elastic, delicate membrane. Anteriorly, the lens contacts the border of the iris, forming the posterior chamber of the eye. It is held in position by the suspensory ligaments. The word cataract is used to describe a lens that has become opaque, so you can't see through it. Cataracts are a condition affecting the eye, not a disease. As the lens gradually clouds, less light is able to pass through, blurring and distorting images received by the retina. Vision is gradually impaired. If untreated, a cataract can cause needless blindness. Cataracts are usually white but may take on a yellow or brown color. The development of cataracts is usually due to the normal part of aging. of the aging process, but they can develop due to other reasons, including traumatic cataracts resulting from an injury or blow to the eye, use of certain drugs, exposure to harmful chemicals, exposure to excessive sunlight, and congenital disease. So this is why when you go to the eye doctor, they always push you to wear your sunglasses, because if you're looking at the sun or if you're outside all the time looking at the sun, you can speed up the process of causing cataracts. Under the equipment, second column, second bullet, there's your intraocular lens implant, or IOL. You'll see this on the board if you're in the eye room. You'll do IOL OD or IOL OS, which is you're going to be doing intraocular lens implants on the left or the right, or IU. And then that last bullet, there's the viscoelastic agents such as Helon or Viscoat. Okay. Under the practical considerations, intracapsular cataract extraction involves a large incision and the entire capsule is removed. Suturing is required for closing the incision. Extracapsular cataract extraction is performed through a small incision and only the lens is removed. Incision is self-sealing with no sutures required. IOLs are small prescription lenses placed inside the eye for clear lens replacement surgery. IOLs may be foldable or hard. Foldable lenses are made of silicone or acrylic and can be rolled up and placed inside a tube that is inserted through the small incision or folded by locking forceps, and once inside the eye, the IOL unfolds. Hard plastic lenses are rarely used and must be inserted through a larger incision. Phacoemulsification is a variation of the irrigation/aspiration technique. The tip of the phaco handpiece is inserted through the small incision and ultrasonic energy fragments the lens while simultaneously irrigating and aspirating the fragments. After the nucleus of the lens is removed, the irrigating aspirating unit is used to remove the remaining pieces of cortex. And this is how we typically will do cataract extraction. We typically do extracapsular because of the no sutures needed, and you're going to be using that phacoemulsifier. All right, so on the next page, the surgical procedure number 6, I'm just having you underline that phacoemulsification handpiece. So there is a handpiece that you use to dissolve that lens. Number 7, the viscoelastic is injected to re-inflate the capsule. So I'm just showing you where that's being used. And you can see what's going on 617. And on pages afterwards. Okay, so on 620, where it says plate 16-14, see how it's folded? I wrote above it that the IOL can be flat, folded, or rolled and passed through a tube, which we underlined, but I'm just reiterating here, and I wrote it here just to make sure that you remember that the IOL can be flat, it can be folded, or it can be rolled and passed through a tube. So that takes us to 621, the vitrectomy. You need to write next to vitrectomy that this is an intraocular procedure. So everything up until this point has been on the outside of the eye or like on the lens. This vitrectomy is an intraocular procedure. We are going into the eyeball. So the posterior cavity of the eye is larger than the anterior cavity since it occupies all of the space posterior to the lens, suspensory ligaments, and ciliary body. The posterior cavity contains a substance with a consistency similar to soft gelatin called vitreous humor. Vitreous humor helps maintain sufficient pressure inside the eyeball to prevent the eyeball from collapsing. The hyaloid membrane encloses the whole of the vitreous humor. And then that second bullet, or third bullet, I guess. When a retinal tear occurs, blood vessels may also be torn and a vitreous hemorrhage may occur. Because of the tear, a detachment may also occur. A vitrectomy is performed to remove the blood so the surgeon can view whether there is a detachment. Then halfway down that last bullet, it says when the detachment involves the macula, central vision is lost. So make sure that you know that macula detachment means that the central vision is lost. Okay, so under the equipment on page 622, there's that second bullet. The phragmatome is an ultrasonic instrument with aspiration used to remove cloudy lens, which obstructs the view of the retina. And then in that second column, there's the McPherson, again a McPherson for the eyeballs. Pre-op preparation, there's the anesthesia, the retrobulbar block. Under practical considerations, so that's second column in the first bullet, there's intraocular. Okay, so these are the different gases. So intraocular, or inside the eyeball, intraocular gases. Halfway down, gas is useful for flattening a detached retina and keeping it attached while healing occurs. Gas injection is also used to close macular holes. It is frequently necessary for the patient to maintain a certain head position following surgery when gas is used. Okay, and then there's silicone oil. This is sometimes used instead of gas to keep the retina attached postoperatively. Silicone remains in the eye until it is removed, which is necessitating a second surgery. Then further down, unlike what they experience with gas, patients are still able to see through clear silicone oil. Positioning is less critical with silicone oil, therefore it may be used with patients who are unable to position themselves appropriately postoperatively. So a silicone oil may be used predominantly like on your elderly patients, especially if they have any kind of tremors, Parkinson's disease, anything like that, or neck or back pain where they cannot hold a position, they may opt for the silicone oil. And then there's the lensectomy on 623. Lensectomy is the removal of the eye's crystalline lens during a vitrectomy procedure. This is sometimes performed when there is a cataract, which prevents the surgeon from adequately visualizing the internal structures. Okay. All right. And then the last one on here is on 625, the repair of traumatic eyelid laceration. So traumatic laceration of the eyelid can be due to blunt and penetrating trauma, including dog bites, penetration by a small tree limb, hit by human fist, and cut by glass, such as during a vehicle accident. And I love how it says a small tree limb. This is whenever you're walking and you run into a tree, or someone is holding the branch and lets go and slaps you right in the face. So under the practical considerations, second bullet, confirm with the surgeon if the canaliculus is involved in the wound. If involved, the veer rod will be needed. So let's talk about the veer rod. So under the surgical procedure, number 2, canaliculus, and you need to write next that that's a small duct. So the canaliculus, which is the small duct, involved. A. Veer rods is placed through the laceration and the canaliculus is approximated with non-absorbable suture around the rod, and then the rod is removed. Okay, so it's just a stabilizer, that veer rod. And that wraps up chapter 16, the ophthalmic surgery.